Every projection relieves a truth, but only when viewed from the right angles. Here we are going to talk about projection geometry. A conventional radiograph is a two-dimensional projection images of a three-dimensional object. Such images are often called plane or projection views. In plane views, the entire volume of the tissues between the X-ray source and the image receptor is projected onto the two-dimensional image. Intraoral radiographs like periapical, bite-wing and occlusal radiographs and cephalometric and skull radiographs are the examples of projection views commonly made in general and the specialty dental practices. The term the image qualities refers to the reliability of the image to present the true state of anatomical region examined. The five basic principles of projection geometries are based on the effects of focal spot, size, relative positions of the object and image receptors on image clarity, magnification and distortions. Moving on to the basic principles of projection geometry for radiograph, there are five basic principles of projection geometry. First one, the focal spot should be small as possible. The source receptor distance should be long as possible. Object receptor distance should be small as possible. Receptor should be parallel to the long axis of the object. The central beam should be perpendicular to the object and the receptor. So what is image sharpness and the resolutions? Sharpness measures how well a boundary between two areas of differing radio density is relieved. Image spatial resolution measures how the well radiograph relieves small objects that are close together. In the figure 6.1 shows that the photons originating at different places of the focal spot, so result in the zones of unsharpness on the radiograph. The density of the image changes from high background value to the low value in the area of the edge of the enamel, dentin or bone. On the left side of the image, a large focal spot size results in the wider zones of unsharpness compared with the small focal spot on the right, which results a sharper image, narrow zones of unsharpness, which means that when X-rays are produced at the target in the X-ray tube, they originate from all the points within the area of the focal spot, because these rays originate from the different points and travels in the straight lines. The projection of an object do not superimpose at the same location on the image receptor. The image of the edge of the object is slightly blurred rather than the sharp and the distant. The resulting blurred zone at the edge of the image causes losses in the image sharpness and is referred to as geometric unsharpness or penumbra. The larger focal spot area, wider the zone of the geometric unsharpness. There are three means to maximize the image sharpness. First one, uses a small effective focal spot as a practical. The effective focal spot size in the dental X-ray machines ranges from 0.4 to 0.7 mm. Usually an X-ray unit with a smaller focal spot size added to the image sharpness. The size of the effective focal spot is a function of the angle of the target with respect to the long axis of the electron beam. The large angle distributes the electron beam over the larger surface and decreases the heat generated per unit of target area. Thus, prolonged tube life. However, this results in a larger radiation source and loss of image clarity. A small angle has a greater wearing effect on the target, but results in a smaller source and increased image. In figure 6.2, as the angle of the target becomes closer to the perpendicular to the long axis of the electron beam, as shown in the right side, the actual focal spot becomes smaller, which decreases the heat dissipations and the tube life. The more perpendicular angle also decreases the effective focal spot size, increasing the sharpness of the resulting image. Moving on to the second point, increasing the distance between the source and the object by using a long open-ended cylinder. Increasing the source to object distance reduces the geometric unsharpness by reducing the divergence of the X-ray beam. A longer source to object distance yields photons when the paths are almost parallel to at the object and minimizes the unsharpness. To facilitate the making images with a longer source to object distance, may manufacturer locate the X-ray tube receive within the X-ray the housing. For intraoral X-ray units, the distance from the source to the edge of the aiming rim ranges from 8 inches to 16 inches. In the image shows that increases the distance between the source and the object results in the image with increased the sharpness and less magnification of object as seen as on the right. Third point, minimizing the distance between the object and the image receptors. So as the object to the image receptor distance is reduced, the divergence of the X-rays photons at the object is less, resulting in a decrease in the width of the unsharp zone. In the figure 6.4, there is a decreasing the distance between the object and the image receptors, increases the sharpness and results in less magnifications of the object as seen on the left. Next, image size distortions is also called magnifications. So increase in size of the image on the radiograph compared with the actual size of the object. Increase the focal spot to the film distance and decrease the object the film distance minimizes the image magnifications. And long open-ended aiming device reduces the magnifications of the image on the periapical view. Image distortions. Unusual magnifications of different parts of image. To minimize the shape distortions, one should make an effort to align the tube object and the film. Using two guidelines. First one, position the film parallel to the long axis of an object. Second one, orient the central ray perpendicular to the object and the film. So in this image, shape distortion is minimized. The long axis of the film and the tooth are parallel. The position imaging receptor parallel to the long axis of the object, so the image shape distortion is minimized when the long axis of the image receptor and the tooth are parallel. Okay. The central X-ray beam is perpendicular to the image receptor, but the object is not parallel to the image receptors. The resulted image is distorted because of the unequal distance. The various parts of the objects forms the image receptor. This type of shape distortion is called as foreshortening because it causes the radiograph image to be shorter than the object. When the X-ray beam is oriented at the right angles to the object but not to the image receptor, this results in elongations, with the object appearing longer on the image receptor than its actual length. Next one. And this is the orientation of the central ray perpendicular to the object and the image receptors. Image shape distortions occurs if the object and image receptors are parallel, but the central ray is not directed at the right angles to each other. This distortion is most evident on maxillary molar views. Whereas the divergence of the buccal and the palatal roots precludes the placing all the roots parallel to the receptor and the palatal roots appears disproportionately longer than the buccal roots. Bisecting and paralleling technique. Paralleling technique is preferred method for making the intraoral radiograph. This technique seeks to minimize the distortion by placing the image receptor parallel to the long axis of the tooth and directs the central ray beam perpendicular to the both long axis of the tooth and the receptors. So to achieve this parallel orientation, The practitioner often must position the image receptors towards the middle of the oral cavity away from the teeth. Although this allows the teeth and image receptor to be parallel, it increases the object to receptor distance and results in some image magnification and geometric unsharpness. To overcome these limitations, this paralleling technique also uses relatively long-ended aiming cylinder cone to increases the source to object distance. This cone directs only the most central and the parallel rays of the beam to the image receptor and the teeth and reduces the image magnifications while increasing the image sharpness. The second method to minimize the image distortion and magnification is in intraoral radiographic is bisecting angle technique. In this method, the image receptor is placed as close to the teeth possible without deforming it. However, when the image receptor is in position, it is not parallel to the long axis of the teeth. This arrangement inherently causes distortions. Although the projection length of the root is correct, this image displays a distorted image of the position of alveolar crest with respect of cemento-enamel junction of the tooth. What are the advantages of paralleling technique? Geometrically accurate images are produced with a little magnifications. Shadow of the zygomatic buttress appears above the species of the molar teeth. Periodontal bone levels are represented. Preapical tissues are accurately shown with a minimal foreshortening or elongation. The crowns of the teeth are well shown, enabling the detections of proximal caries. Horizontal vertical angulation of the X-ray tubes are automatically determined by the position device if placed correctly. The X-ray beam is aimed accurately at the center of the image receptor. All the areas of the image receptors are irradiated and there is no coning off or cone cutting. Reproducible radiographs are possible at different visits within the different operators. Relative positions of the image receptor, teeth and X-ray beam are always maintained irrespective of the positions of the patient's heads. This is useful for some patients with disabilities. Disadvantages of paralleling technique. Positioning of the image receptor can be very uncomfortable for the patient, particularly for the posterior teeth, often causes gagging. Position of the holder within the mouth can be difficult for inexperienced operators, particularly when using the solid-state digital sensor. The apices of the teeth can sometimes appear very near the edge of the image. Positioning the holders in the lower third molar regions can be very difficult. The technique cannot be performed satisfactorily using a short focal spot to the skin distance because of the resultant magnifications. The holder needs to be autoclaved or disposable. What are the advantages of bisected angle technique? Positioning of the image is reasonably comfortable for the patients in all the areas of the mouth. Positioning is relatively simple and quick. If all angulations are assessed correctly, image of the tooth will be same length as the tooth itself and should be adequate for the most diagnostic purpose. Disadvantages. The many variables involved in this technique often results in image being badly distorted. Incorrect vertical angulation result in the foreshortening of the image. Periodontal bone levels are poorly shown. The shadow of the zygomatic buttress frequently overlies the root of the upper molars. If it is not possible to obtain the reproducible views, coning off or cone cutting may result if the central ray is not aimed at the center of the image. Incorrect horizontal tube head angulation will result in overlapping of the crowns and the roots. The crown of the teeth are often distorted, thus preventing the detections of the proximal caries. The buccal roots of the maxillary premolars and molars are foreshortened. What is object localizations? To determine the location of the foreign object or impacted tooth within the jaws. So, the approaches the three-dimensional radiographs by radiography examine the two conventional images are projected at the right angles to each other Using the tube shift technique employing the conventional periapical views, image the anatomic region with three-dimensional imaging modalities. Two methods to use to obtain the three-dimensional images. First method is X-ray taken at the right angle to one another, and second method is tube shift technique or buccal object rule or Clark technique. The first image, which shows that the position of the object may be determined with respect to the reference structures with the use of the tube shift technique. So in a first image A, the radiograph object of the lingual surface of the mandible may appear apical to the second premolar, when other B represents when the other radiograph is made to this region angulated from the mesial, the object appears to have moved mesially with respect to the second premolar apex. It's called as same lingual and also called slope technique. When the object lies lingual to the reference object, its image moves in the direction of the tube shift. And second image shows that the position of the object can be determined with respect to the reference structure with the use of tube shift technique. A. An object of the buccal surface of the mandible may appear apical to the second molar, when another radiograph is made of this region angulated from the mesial, the object appears more distally with the respect of second premolar apex is called opposite buccal is called slope technique. When the object lies buccal to the reference object, if image appears to move in the direction of the opposite of the tube shift. Eggshell effect. Plane radiograph images that projects a three-dimensional volume onto the two-dimensional receptor may produce an eggshell effect of your corticated structures. The top photon has a tangential path through the apex of the egg and much longer path through the shell of the egg, and thus lower photon which strikes the egg at the right angle to the surface and travel to two thickness of the shell. As a result, the photons traveling through the periphery of a curved surface are more attenuated than the photons traveling at the right angles of the surface, which shows an expansile lesions of the buccal surface of the mandible on the occlusal view. The periphery expanded cortex is more opaque than the region inside the expanded border. The cortical bone is not thicker on the cortex than over the rest of the lesion, but rather the X-ray beam is more attenuated in the region because of the longer path length of photons through the bony cortex on the periphery. The eggshell effects accounts for wide normal structures such as lamina dura, border of the maxillary sinus, and nasal fossa, and abnormal structures including the cortical wall cyst, benign tumor, are well demonstrated on the plane radiograph. Soft tissue masses such as nose and tongue do not show the eggshell effect because they are uniform rather than being composed in a dense layer surrounded by the lucent interior. So in this image, figure A, radiograph of the hard-boiled egg. Note how the rim, the eggshell, is opaque even though uniform in thickness. In image B, the view of egg being exposed on the X-ray beam, the top photon has a tangential path through the apex of the egg and a longer path to the shell of the egg than the lower photons. As a result, photons traveling to the periphery of the curved surface are more attenuated than the photons traveling at the right angles to the surface. In figure C, a expansile bone lesion on the buccal surface of the mandible, a cross-sectional occlusal view. The expanded cortex is more opaque than the region inside the border as a result of the eggshell